Support for the Journal of Clinical Oncology podcast is provided in part by AstraZeneca, dedicated to advancing options and providing hope for people living with cancer. More information at AstraZeneca-US.com.
Welcome to this episode of JCO Article Insights. This is Michael Hughes, JCO's editorial fellow. Today I have the privilege and pleasure of interviewing Dr. Suzanne Lentzsch on the co-occurrence of cytogenetic abnormalities and high-risk disease in newly diagnosed and relapsed refractory multiple myeloma by Dr. Kaiser and colleagues. At the time of this recording, our guest has disclosures that will be linked in the transcript. The urge to identify patients with aggressive disease, which is the first step in any effort to provide personalized medical care, is intuitive to physicians today. Multiple myeloma patients have experienced heterogeneous outcomes since we first started characterizing the disease. Some patients live for decades after treatment. Some, irrespective of treatment administered, exhibit rapidly relapsing disease. We term this high-risk myeloma. The Durie-Salmon Risk Stratification System, introduced in 1975, was the first formal effort to identify those patients with aggressive high-risk myeloma. However, the introduction of novel approaches in therapeutic agents, autologous stem cell transplantation with melphalan conditioning, proteasome inhibitors like bortezomib, or immunomodulatory drugs like lenalidomide, rendered the Durie-Salmon system a less precise predictor of outcomes. The International Staging System in 2005, predicated upon the burden of disease as measured by beta-2 microglobulin and serum albumin, was the second attempt at identifying high-risk myeloma. It was eventually supplanted by the revised International Staging System, RISS, in 2015, which incorporated novel clinical and cytogenetic markers and remains the primary way physicians think about the risk of progression or relapse in multiple myeloma. Much attention has been focused on the canonically high-risk cytogenetic abnormalities in myeloma, typically identified by fluorescence in situ hybridization, translocation 414, translocation 1416, translocation 1420, and deletion of 17p. Much attention also has been focused on the fact that intermediate risk disease, as defined by the RISS, has been shown to be a heterogeneous subgroup in terms of survival outcomes. The RISS underwent revision in 2022 to account for such heterogeneity and has become the R2ISS, published here in the Journal of Clinical Oncology first in 2022. Translocations 1416 and 1420 were removed, and gain or amplification of 1Q was added. Such revisions to core parts of a modern risk stratification system reflect the fact that myeloma right now is in flux, both in treatment paradigms and risk stratification systems. The field in the recent years has undergone numerous remarkable changes, from the advent of anti-CD38 agents to the introduction of cellular and bispecific therapies to the very technology we use to investigate genetic lesions. The major issue is that we're seeing numerous trials using different criteria for the definition of high-risk multiple myeloma. This is a burgeoning problem and speaks very much now to a critical need for an effort to consolidate all these criteria on at least cytogenetic lesions as we moved into an era of response-adapted treatment strategies. The excellent article by Kaiser and colleagues published in the February 2025 edition of the JCO does just that in a far-ranging meta-analysis of data from 24 prospective therapeutic trials. All 24 trials were phase 2 or 3 randomized controlled trials for newly diagnosed and relapsed refractory multiple myeloma. The paper takes a federated analysis approach. Participants provided summaries and performed pre-specified uniform analyses. The high-risk cytogenetic abnormalities examined were translocation 414, gain or amplification of 1Q, deletion of 17p, and translocation 1416 if included in the original trials. All of these were collected into 0, single, or double hit categories, not unlike the system currently present in diffuse large B-cell lymphomas. The outcome studied progression-free survival and overall survival, with these analyses adhering to modified ITT principles. The authors also performed pre-specified subgroup analyses in the following: transplant-eligible newly diagnosed myeloma, transplant non-eligible newly diagnosed myeloma, and relapsed refractory myeloma. They in addition described heterogeneity by the I-squared statistic, which, if above 50%, denotes substantial heterogeneity by the Cochrane Review Handbook, and otherwise performed sensitivity analyses and assessed bias to confirm the robustness of their results. In terms of those results, looking at the data collected, there was an appropriate spread of anti-CD38 containing and non-containing trials. 7,724 patients were evaluable, of a total 13,926 enrolled in those 24 trials, 4,106 from 9 trials in transplant-eligible myeloma, 1,816 from 7 trials in transplant non-eligible myeloma, and 1,802 from 8 trials in relapsed refractory disease. ISS stage for all patients was relatively evenly spread. Stage 1, 34.5%, Stage 2, 37%, Stage 3, 24%. In terms of high-risk cytogenetic lesions, double-hit disease was present in 13.8% of patients, and single-hit disease was present in 37.4%. In terms of outcomes, Kaiser and colleagues found a consistent separation in survival outcomes when the cohort was stratified by the number of high-risk cytogenetic lesions present. For PFS, the hazard ratio was for double hit 2.28, for single hit 1.51, without significant heterogeneity. For overall survival, the hazard ratio was for double hit disease 2.94, single hit disease 1.69, without significant heterogeneity except in patients with double hit disease at 56.5%. By clinical subgroups, hazard ratios remain pretty consistent with the overall cohort analysis. In transplant-eligible newly diagnosed myeloma, the hazard ratio for progression is 2.53, overall survival 4.17. For transplant non-eligible, 1.97 progression, 2.31 mortality. Relapsed refractory disease progression 2.05, overall mortality 2.21, without significant heterogeneity. Of trials which started recruitment since 2015, that is to say, since daratumumab was FDA approved and thus since an anti-CD38 agent was incorporated into these regimens, analysis revealed the same results, with double-hit myeloma still experiencing worse survival by far of the 3 categories analyzed. Risk of bias overall was low by advanced statistical analysis. In terms of subgroup analysis, double-hit results for transplant-eligible newly diagnosed myeloma may have been skewed by smaller study effects, where the upper bound of the estimated hazard ratio for mortality reached into the 15-20 to 20 range. In conclusion, from a massive amount of data comes a very elegant way to think about the role certain cytogenetic abnormalities play in multiple myeloma. A simple number of lesions, 0, 1, or at least 2, can risk stratify. This is a powerful new prognostic biomarker candidate, and somewhat soberingly also may confirm, or at least suggests, that anti-CD38 agents are unable to overcome the deleterious impact of certain biologic characteristics of myeloma. Where do we go from here? This certainly needs further a priori prospective validation. This did not include cellular therapies. The very scale at which this risk stratification system operates, agnostic to specific genetic lesion, let alone point mutations, lends itself also to further exploration. And to discuss this piece further, we welcome the one and only Dr. Suzanne Lentzsch to the episode. Dr. Lentzsch serves as an associate editor for JCO and is a world-renowned leader at the bleeding edge of plasma cell dyscrasia research. Dr. Lentzsch, there are several new investigations which suggest that translocation 414, for example, is itself a heterogeneous collection of patients. There are other studies which suggest that point mutations in oncogenes like TP53, which were not assessed in Kaiser et al., carry substantial detrimental impact. Is this classification system, no hit, single hit, double hit, too broad a look at tumor genetics? And how do you think we will end up incorporating ever more detailed investigations into the genetics of multiple myeloma moving forward?
Michael, first of all, excellent presentation of that very important trial. Great summary. And of course, it's a pleasure to be here with JCO and with you to discuss that manuscript. Let me go back a little bit to high-risk multiple myeloma. I think over the last years, we had a lot of information. What is high-risk multiple myeloma? And I just want to mention a couple of things that we separate not only cytogenetically high-risk multiple myeloma, we also have functional high-risk multiple myeloma with an early relapse after transplant within 12 months, or 2 years after start of treatment for the non-transplant patients, which is difficult to assess because you cannot decide whether this is a high-risk patient before you start treatment. You only know that in retrospective. Other forms of high risk, extramedullary disease, circulating tumor cells / plasma cell dyscrasia, patients who never achieve MRD positivity, extramedullary multiple myeloma, or even age and frailty is a high risk for our patients. Then we have gene expression and gene sequencing. So there's so much information currently to really assess what is high-risk multiple myeloma. That is very difficult to find common ground and establish something for future clinical trials. So what Dr. Kaiser did was really to develop a very elegant system with information we should all have. He used 4 factors: translocation 14/16, 4/14, gain or amplification of 1q, and deletion of 17p. Of course, this is not the entire, I would say, information we have on high risk, but I think it's a good standard. It's a very elegant system to really classify a standard single hit, double hit, high risk multiple myeloma, which can be used for all physicians who treat multiple myeloma, and especially it might also work in resource scarce setting. So ultimately, I think that system is an easy to use baseline for our patients and provides the best information we can get, especially with a baseline in order to compare clinical trials or to compare any data in the future.
Thank you, Dr. Lentzsch. To the point that you made about this isn't the full story, there does, as you said, exist this persistent group of functional high-risk multiple myeloma, where we see standard risk cytogenetics, but these patients ultimately either exhibit primary refractory disease or very early relapse, despite standard aggressive treatment. How do you see risk stratification systems incorporating other novel biomarkers for such patients? Is it truly all genetic? Or is next-generation sequencing, gene expression profiling, is that the answer? Or is there still a role for characterizing tumor burden?
Excellent question, Michael. And I wish I would have the glass bowl to answer that question. I see some problems with the current approach we have. First of all, to do the cytogenetics, you need good material. You only detect and identify what you have. If the bone marrow is of low quality, you have mainly peripheral blood in your bone marrow biopsy, you might not really fully have a representation of all cytogenetic changes in your bone marrow. So I think with a low quality sample that you might miss one or the other really cytogenetic high risk. So having said this, I think circulating tumor cells, that might be something we will look into in the future, because circulating tumor cells are readily available, can be assessed without doing a bone marrow biopsy. And what is even more exciting, in addition to the circulating tumor cells or plasma cells, using them is next-generation sequencing. I think at the moment we are more in a collection phase where we really try to correlate sequencing with our cytogenetics, and especially to establish next-generation sequencing in all of our patients. But I think after that collection phase, maybe in the future, collecting peripheral blood and doing sequencing on peripheral blood samples might be the way to go. In addition, I don't want to forget the imaging. We started with a skeletal survey, and we know that you probably need to lose 30% of the bone before you see a lesion at all. So having imaging such as diffusion-weighted imaging, whole body MRI, is also, together with sequencing of the tumor cells, a step into the right direction.
Thank you, Dr. Lentzsch. Bringing this back to the article at hand, how has Kaiser et al. Changed the way we discuss myeloma with patients in the exam room?
I think we have more data on hand. So far, we talked about standard risk and high risk. But I think right now, with a very simple system, we can go into the room and we can tell the patient, listen, you don't have any of those cytogenetic abnormalities. I think you have a standard risk. We might give you a simple maintenance treatment with Revlimid. But we might also go into the room and say, I'm really concerned. You have so-called double-hit multiple myeloma, you have high risk, and at least 2 of those abnormal cytogenetics, which we discussed. And I think you need a more intense maintenance treatment, for instance, double maintenance. I think we know that a high-risk multiple myeloma can be brought into a remission. But the problem what we have is keep those patients into a remission. So I think a more intense treatment, for instance, with a double maintenance or with consolidation after transplant and a longer and more intense treatment is justified in patients who have that truly high-risk multiple myeloma described here.
Dr. Lentzsch, thank you so much for your time and your wisdom.
My pleasure. Thank you for having me.
Listeners, thank you for listening to JCO Article Insights. Please come back for more interviews and article summaries, and be sure to leave us a rating and review so others can find our show. For more podcasts and episodes from ASCO, please visit asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.